Well, good morning, everyone. On behalf of all of us, I know we're always very excited about this day where we get to celebrate some of our residents and educators and our residents who are graduating, and always kick this off with one of our residents who will give a presentation about some of the research that they've been doing during their time in residency. And so I am thrilled to introduce our speaker today, Dr. Paul Witt. So Dr. Witt grew up in Omaha, Nebraska. He graduated from Creighton Prep High School in 2014. He completed his undergraduate degree at Marquette University in Milwaukee, Wisconsin in 2018, and then completed medical school at the University of Nebraska College of Medicine, graduating in 2022. He is currently a second-year pediatric resident in our program here, and is going to be one of our co-chief residents for the 2025-2026 year. He's planning to pursue a career in pediatric hospital medicine, and as we will find out today, has a very strong interest in medical education. So I will turn it over to Dr. Witt.
All righty, well, good morning, everybody. Thank you for that introduction. Appreciate it, Dr. Goodrich. So just want to say, first of all, thanks everybody for coming to Grand Rounds this morning. Nice to have people in the audience. I feel like most presentations I'm kind of used to doing just over Zoom, so a little different. But so yeah, as part of the Child Health Research Institute Research Forum, I get to be lucky enough to present my research project to you guys. So thanks for listening today. As Dr. Goodrich said, I have an interest in medical education, and so kind of the big piece of my research project is about medical education and how we teach medical students about the social determinants of health. Okay. I have no disclosures. Objectives for today. So number one, just kind of talk about social determinants of health. Two, we're going to talk a little bit about qualitative and quantitative research methodology, and kind of, I feel like, at least for me, qualitative research was kind of a new thing, so a little bit of an intro for those that also felt that way. And then finally, we'll kind of talk about what medical students reflect on when they talk about social determinants of health. We have a poll editor slide. I had issues with it trying to get to work last night, so we're just going to skip it altogether. So I just kind of put this out there as like a rhetorical question. Feel free to think about it. But approximately what percentage of health outcomes can be attributed to the clinical care that a patient receives? The spoiler is obviously my talk is on social determinants of health. So take that how you will. I guess the answer is actually 20%. So I think if I had seen this question, I would have guessed maybe 40 to 60. But 20% is even kind of an overestimate. A lot of studies say that between 10 to 16% of health outcomes, whether it's mortality, morbidity, quality of life, those all they are attributed 10 to 20 to 16% of being attributable to clinical care. And we'll kind of swing back around to that a little bit later. Okay, so social determinants of health. What are they? So social determinants of health, as the World Health Organization defines them, they are the non-medical factors that influence health outcomes, the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So this particular chart is from Healthy People 2030. This is put out every decade or so by the CDC, and essentially it is a set of health objectives for the next 10 years that they hope to accomplish on a national level. As you can see, it's broken up into 5 different domains, which will become relevant a little bit later. I think this brings up, obviously, the point of pediatrics and how does this impact our patients. I think it's important to note that, as a lot of you guys know, pediatric patients are particularly susceptible to the social determinants of health, I feel. They rely on others for their care, and they also face long-term implications for their health. Some just quick statistics about children. Impoverished children are more likely to experience low birth weight, learning disabilities, mental health disorders, iron deficiency anemia, asthma, burns and injuries, obesity, and hospitalization than their more affluent peers. Coming through and reading some studies, you can see that the socioeconomic status of children when they're adults, you can see those impacts lasting kind of throughout life. And even if children grow up and they are able to change their socioeconomic status and they're in a higher socioeconomic status, it never fully corrects, and there's always lasting impacts that can be seen throughout life. So kind of this brings us back to the question I asked at the beginning. And this particular study was a review of the county health records or rankings on a national level, and they made a model to try to predict how can we predict the contributions of each of these domains to health outcomes. And so the numbers that they came up with, and other studies kind of show similar ones, are about 47% can be socioeconomic, 34% health behaviors, 16% clinical care, and 3% the physical environment. Overall, most studies kind of fall in the 30 to 55% range of what they attribute to social determinants of health and how they impact health outcomes. Okay, so kind of crossing over into the medical education side of things. Kind of across the country, it's become pretty much the standard that education about social determinants of health is implemented in curriculum, and kind of a panel of experts recommend that between 13 to 15% of time should be dedicated to instruction on these topics. Okay, qualitative research. This is the good stuff. So first question you ask is, what is qualitative research? Because I definitely asked that right away when I started this. And this is how I felt. This is actually, funny enough, I ran into this when I was preparing this PowerPoint, and this is a picture from my first research project in undergrad when I was doing some bench research looking at biochemical markers of stress in mice. Okay. And then I also wanted to share this quote that I thought was fascinating. So I was kind of skeptical of qualitative research at first, and I think a lot of it stems from, in medicine, we're really, really familiar with quantitative research. We learn about stats, we learn about numbers, we learn about p-values. And so I think this was great. Qualitative research is heading towards a renaissance. Once it was derided as the ugly duckling, inferior to the majestic swan-like ways of quantitative research. Sad. And so kind of breaking it down, what is quantitative and qualitative research? We kind of break down research methodology into these two big categories, with the addition of mixed methodology, a combination of both of them, which is kind of beyond the scope of this talk. But in its most basic sense, quantitative methods are looking at numbers, they're looking at stats, and then qualitative methods are looking at words and thoughts and ideas. And then to kind of break it down a little bit more, there's a lot of nuance between these in the end, but I think the big things to take away are, quantitative, you're trying to compare variables and see relationships. I like to think of it as you're trying to prove something or you're trying to test something, as opposed to qualitative methods, you're looking at trying to understand a little bit better and be able to explore a concept. Okay, this figure here kind of breaks down a lot of the different types of research methods and kind of where they fit in the grand scheme of things. This was coincidentally taken from a textbook by John Cresswell, who is a professor at Lincoln and was considered a world-renowned researcher in mixed methodology, and I think even some would call the founder of mixed methods research, which is super cool that he was here in Nebraska. So my topic kind of falls in this qualitative research category. And to help you follow down, this would be considered kind of narrative research. And so we're looking at reflections of students and kind of trying to piece together what that says about their lives and their experiences. Okay, so kind of talking a little bit more about the ugly duckling and majestic swan. I think this particular point from this paper was kind of where it really drove home how important qualitative research is, and how it's kind of, it's not just the ugly duckling, it also has a lot of great richness and depth that it can bring to scientific knowledge. So imagine a study focusing on diabetes and insulin compliance. So first you can ask, what's the relationship between, say, the A1C and disease progression. You can look at numbers and you can map that out, find variables. That's kind of the quantitative side of things. Versus, why are patients non-compliant? These are kind of the questions we ask with qualitative research. How do they understand their disease? Do they understand how it's progressing? What is their concept of diabetes and of compliance? And kind of this can be taken into kind of what are the barriers to getting to having better compliance and less disease progression. And so I think this really, at least to me, brought home the point of like these questions that we ask in qualitative research, even though there aren't numbers behind them, there isn't values and, you know, the traditional things we look at when we think of research and kind of showing importance and significance of things. This also has a lot of important information that if we kind of forget about, we kind of miss out on and can really be impactful for both kind of how we practice medicine and ultimately the care that our patients receive. And so ultimately, even though it's not an ugly duckling, or not a swan, and probably not an ugly duckling, they're not total opposites, and they're described as different and complementary ways of viewing similar phenomena. And so I think it's important to think of them as working together to paint the full picture of information. Okay, so getting into my research project. Okay, so our study design. It's considered a retrospective thematic analysis of discussion board posts. So essentially, the third-year medical students during their pediatric clerkship, they write a reflection post that they post onto the Canvas electronic, the management software online for their class, and they're supposed to reply, respond, interact with each other, trying to learn about social determinants of health. And so we looked at these posts from the 21 to 22 academic year. For those of you keeping track, the N is 97. We only use 5 out of the 6 cohorts of the year, just from timing of when we started the study. And so our big study goals were trying to find the big social determinant themes that students talk about and what they experience when they're in the pediatric clerkship. And then ultimately, is there a way that we can kind of look into their reflections and understand the depth of their reflections by looking at how the interventions they describe towards their experiences, how that is kind of reflective of their understanding of things. And we use this software called MaxQDA, which is a qualitative data analysis software, which it has a big learning curve, but it's very useful. So the discussion board prompt. Reflecting on your experience in the clerkship, analyze the social determinant of health and our healthcare system. How do those interact and impact patients? And then identify opportunities for change in the system, quality improvement, and or advocacy to improve patient outcomes. So, diving into our methods a little bit. There will be a lot of talk of coding. There are a lot of rounds of coding. I read through all the posts more times than I could count. But ultimately, the beginning of kind of most qualitative research is you have to familiarize yourself with the general content and just be familiar with kind of the things that people are talking about. So reading through the posts a number of times to kind of get a little bit of that background and that understanding beforehand. We first conducted a round of coding kind of in an inductive way. And so I'll talk briefly about inductive and deductive processing because I ultimately had to review it for this talk myself. Inductive is kind of taking, I think of it as increasing, so you're taking information from kind of the foundation and taking themes away from that is how it was incorporated into our study. And so we're not trying to apply something to the post, but just what's in there, what's the content like. We conducted a second round, overlapping separate kind of on its own. And what we did here was we looked at those 5 domains from the Healthy People 2030 objectives that I showed earlier. And that is more the deductive. So you take a framework, a pre-existing theory, and try to apply it to what you have in front of you. And so you're kind of doing that top-down processing. Finally, we did another round of coding, as you can guess. And we looked at it in this social ecological theory. And so I'll kind of come back to what that theory is. but kind of looking at the interventions that students propose and how that can ultimately maybe give us some insight into their understanding of social determinants of health. So this is a quick little excerpt from a post. I actually think it was a reply to a post, so not relevant for technically this this particular research project, but I think this kind of highlights what the coding process looks like, just to give an example. So it's unfortunate that some clinics don't accept certain forms of insurance, and that these families then need to add in obstacles of distance in planning in order to obtain the same health care that they would that they could have much closer if insurance wasn't a problem. And so kind of an example of what this looks like is when you're looking for themes, one that you could say from this particular little blurb is they're having issues with access to care. And then kind of diving into the kind of nuance of this, you could argue, depending on how the post started, they talk about insurance and maybe they talk about finances. So it's a little bit of, there's a little bit of subjectivity to it, but ultimately we had a couple of reviewers, so we can kind of make sure that we're all on the same page, and if we have disagreements, kind of talk it through and find a nice middle ground. Okay, social ecological theory. You guys are learning a lot of theories this morning. So social ecological theory, it's been used in the public health fields for decades, and what it does is it tries to conceptualize the interaction between individuals and factors that can influence their behavioral change that are around them. And so this particular one is kind of based on a similar figure from the CDC, the Department of Health and Human Services, but you can kind of see how these bigger overlapping ovals, you start with the individual, then you see the interpersonal relationships, you look at organizational levels, community levels, and then ultimately public policy and kind of bigger societal levels. So a lot of background, a lot of theories, a lot of new things maybe, and now just some fun, pretty pictures. So this is kind of the breakdown frequency of what the main themes that students talked about were. Within this being a qualitative research paper, the numbers don't mean a whole lot, truthfully, but just kind of the general content of the big things students talked about were social support, communication, healthcare access, and then less and less down. But knowing that those are kind of the big things that students talked about, the things they experienced, the things they took away from their experiences on the pediatric clerkship. Hopefully this shows up okay. So this is probably the most complicated slide in this entire presentation, so I'll try to break it down a little bit. And hopefully you guys can see the light gray lines between things. So this is kind of, within qualitative research, trying to map out and give a visual of what we take away from these posts and kind of how they are interconnected, and then kind of trying to give a diagram to map things out. So there's this aspect of the software where you're able to make these maps, and you can do them in various ways, but I felt like this was the best representation, trying to drive home the point of some of the things that we took away from reading through the student reflections. And so this ultimately shows kind of the relationships between these different topics. So the outer circle there are all the themes. Those are the things we found from the inductive part, where we're taking the themes away from the post and kind of what are the things people are talking about. So that's kind of the outer circle. The inner circle are those 5 domains of the social, or the 5 domains of the Healthy People 2030 social determinants of health. And so ultimately, each of those lines represents where there was some overlap between kind of the inductive and deductive processing. And you can see that almost every single one of the themes on the outside is connected to almost all of the themes within the Healthy People 2030, which I think is fascinating. And that shows, I think, that, you know, students really did understand the complexity of social determinants of health and how it's oftentimes multifactorial. There's not always a perfect answer. There's a lot of things at play. And I think that this really drives home the point of, this is a complex topic, but I think that it's really great that students are able to understand this and that you can see it in their discussion posts, which is super cool. Kind of talking about the social ecological theory. This is kind of the breakdown. So what we did when we were coding for these is if students talked about more than one, we ended up choosing the highest level or the progressing from individual up to public policy, we erred towards the side of the higher level. If they talked about a couple, to try to say, does this show kind of how well students understand, or can this be used in any way to kind of represent that? And I think it's also very reassuring that students are able to see, the big picture with some of these issues. And I guess I wasn't expecting the public policy to be that high, for example, but students would notice these things kind of in their individual interactions, and yet they would come up with some of these interventions that really targeted, community level, public policy level, and they're really trying to expand to bigger levels of society, which is super, super cool. So an example of this, just to kind of explain what this kind of these categories. So I didn't use individual for my example because there are only a couple posts. It might be too identifying, but for example, from an interpersonal intervention, someone might say, we could utilize other members of the care team to help address the issue or barrier that they talked about. Going up to the public policy level, there were several that talked about advocating for more funding for WIC, whether it's at the state level or the national level, if WIC was a barrier for their patients. So kind of the big takeaways from the results of this study, I think trying to look at just the themes that we see, there are a lot of themes that the students talk about, and ultimately the social support and communication were the two biggest. A little over half of all the posts were about that, and so I think that is really telling about kind of what students are experiencing, what they're grasping onto. And then kind of like I said with that wild map that you guys saw, students really understood the complexity of this topic and demonstrated, how this is so multifactorial, and they talked about it in their posts. I think that was very evident across the board, which was really something to see. And then finally, kind of like I said, you saw that a lot of the students reflected on kind of those higher level topics when they're looking at what levels of society they're looking at interventions for. And I think that is also super, super cool. Just kind of some future directions. So still kind of finalizing some of the pieces of this project, but we were able to start kind of working on this multi-site study with Iowa and Cincinnati and kind of comparing experiences between our students and theirs and seeing, do different setups for clerkships have any difference in what students are experiencing, or kind of how locations of universities, just how those kind of things can impact what students are experiencing when they're learning about social determinants of health. Because we know that those clinical experiences are huge, and I think that those are some of the best ways we learn, and so I think having those experiences is really, really crucial to medical education and progressing along that way. Those are my references. Yeah, and so that is my research project. Again, I appreciate you guys all being here, and if you have any questions, I'd love to answer them.
Very nice study and presentation. Thank you. There's so much we can learn from qualitative analysis that we just haven't scratched the surface of yet in all aspects of disease. And I'm kind of wondering, for your study, were there areas that you expected to see that you didn't find very prominent, let's say?
Within like the themes that we saw?
Yeah.
I suppose kind of yes and no. I feel like I knew just things that I had personally experienced, and so would I see those things? But I felt like across the board, kind of all the themes that we saw seemed to be ones that I feel like either I had experienced or something that I heard a classmate had experienced, or things like that. So I don't know if there's anything necessarily from this that was like surprising or unexpected. I think it was kind of expected, but maybe kind of the way that it came about was a little unexpected. I feel like the thing that was probably most surprising to me, at least, was kind of that interconnected part where students were talking about multiple things. And I thought that was really great, as opposed to, I don't know, taking the easy route and just saying like, oh, this is my one topic and I'll talk about that one thing. And then also kind of that depth of their reflection in that experience, and then applying that to the intervention, I thought was something that I was a little surprised about, is how well students grasp that and then were able to apply that to kind of a higher societal level than maybe where they experience it, whether it was just a barrier for one person that may not apply to a lot of people. And I thought that was really interesting to me, at least.
Again, great talk. I'm very impressed. Were you able to get a feeling, what did you say, it has to be 13% of the medical school curriculum? So
yeah, 13 to 15, yep.
Were you able to tell if our medical school curriculum has layered this education so that they're seeing it in phase 1 and then pulling it out in their clinical experiences in phase 2? Was that something you were able to tease out if that was why they were perhaps functioning at such a high level?
And so I think, yeah, to that, that's a great point, because I think that it really is already kind of built in, and this class was one that when they were first-year medical students, there's actually a paper that I had read from another medical student in, I guess, class above me, but it ended up being my class for a little bit. He ended up pursuing like a master's of public health, but he had done a study, and they had done an advocacy workshop for the first years. And so I can say that this class in particular was for sure the first ones that experienced that. And so I think even from the beginning of medical school for them, that was already kind of built in. I don't know if I could say specifically along the way how much or try to quantify it in any way, but I'd say at the time that I had done this study, those students that had been from the time that they had started medical school, that it had been already starting to lay the groundwork for that. And so I think it's probably become more robust across the board since then, but at the very least, they were starting to get a little bit of that. So that was kind of one of the things that I was thinking about looking at, too, is kind of like, was there some kind of priming of some of these topics along the way? And so I'm sure that there was, and I think it'd be interesting to try to repeat the study in 5 to 10 years and see, if there's even more greater depth and understanding for students when they have even more of that built into their curriculum.
Did you see, my last question,
yeah.
Did you see a difference, or did you even have the bandwidth to analyze, like, were the themes more robust at the end of the cohort versus, if it was their very first rotation? And that was another one of my questions, too, that I was thinking about exploring kind of in the next steps is kind of if you're looking across the whole spectrum, if it does change. Or another thing kind of to that point of like, did students talk about the pediatric clerkship, or were they talking about other clerkships, which I thought was also kind of interesting how that would change things. So more to come with that. But yes, I have the exact same question, and I think it'd be interesting to see kind of what that looks like. Yeah.
As a future attending and teacher, like as a resident, there any like perspectives that you read that made you want to change the way that you interact with students, or like made you want to change anything about the program as a whole and like how we interact with students?
That's a great question. I think kind of the big takeaways that I took from reading through things is just making sure to address these barriers. Not that any students said that their attendees they worked with or the residents they worked with didn't talk about the topics, but I think it's just that a lot of people are aware of the topics, and just making sure that you're not just saying, oh, we know about this, brush it to the side, but trying to focus on what the issues are and if there are barriers to care, if a patient's being readmitted or they're non-compliant with their medication, trying to look at those things too. And so I think it just kind of reinforces the need to look at all aspects of the patient, kind of from that like biopsychosocial model, and trying to make sure that you're not excluding any of that information. And so I don't know if there's anything I would change from like like necessarily higher practice, but more just trying to be a little more aware of it, and talking about those topics and having those conversations and trying to, kind of push learners along and trying to think about how do you deal with these topics, and especially when you're looking down the line of practice, how do you do that as a physician on your own and as an attending on your own down the line? I think that those are some things to be thinking about, because a lot of the stuff doesn't have perfect solutions, but to be thinking about, I think, is an extremely important part of medical education.
Yeah. First of all, that was a great presentation, Paul, and it's been a lot of fun watching you. I know you presented this at ComCep and how this has now evolved into, it looks like it's going to be a multi-site research project. And my question is a little more general, just about, your involvement in this. And I think and I remember experiencing this, just the thought of that barrier to entry into research with no background can sometimes be really intimidating, and then the time commitment as a student or a resident with all the other directions you're pulled in can be a lot. And so I'm just curious, do you have any advice or, thoughts as you reflect on your experience with this for a resident or a student who might be thinking about getting involved in a project, but that, getting in, just started seems intimidating?
Totally, and I can't say enough about how intimidated I was starting this project, because hearing about qualitative research and mixed methods, grounded theory, I read so many papers, and at the end of the day, reading countless papers, I still didn't understand it great. So I totally understand that. I think ultimately, kind of the how do you get involved piece of it, I think it's kind of just telling people about your interests, and, along the way, a lot of stuff kind of comes up that you may not always expect. So, for example, I was kind of working on a separate research project, and then this one kind of came out of the blue and as an idea, and I got asked to help out with it, and here we are now, a couple years later. And as far as trying to balance things, that has been a challenge, definitely. But I think it's great to have good mentors that are patient with you and understanding that it's hard to get things done always the quickest if you're on a busy month. And then just trying to take advantage of those times where it's a little lighter and saying, it's nice that I have a little downtime, but I should also not forget that thing that I was waiting until the end of my hard month to get started on or so on. And so I think it's been great having the people involved in this project along the way, and I thank them if they're listening for helping me out with this project along the way. But I think having good mentors is great, and I think talking with people, if you hear that they have an interest you have an interest in, let them know. And that was my biggest thing, is I talked to the people that are involved in medical education, because that was something that was important to me, and then I got to do this really cool project, and I think that was kind of the way that I found my entry into this project.
Well, great job with this. You should be very proud of the work you've done.
We have one quick comment and question in the chat. Any chance of expanding this to include Creighton medical students here in town, or is the IRB too difficult? With that, and sorry, go Jays.
That's a great question. It definitely could be. I mean, I think that would be kind of the natural progression. I know I talked about we're working on a project with Iowa and Cincinnati, and I think the pediatric clerkship here is kind of between Creighton and UNMC. The overlap is all over the place, where they're doing a lot of the same stuff, so it'd make a lot of sense to have them as kind of the next cohort to be incorporated. I don't know how the IRB would look for that, truthfully, because I've only ever done one.
Okay.
It would? Okay. So apparently we could do that, and that would be okay. So that might be something we look at in the future as part of this bigger study, which would be really cool to have another perspective from here in Omaha as well.
That'd be a great control group, too, to kind of look at what is being provided at the different schools in the initial stages of medical education, since their clinical time is pretty similar, at least on pediatrics.
That's a great point, yeah. They really would, yeah. That's awesome. Thank you.
More work for you.
I'll add it to the list.